Kashyap Patel is going to speak on HNF1A MODY. The MODY itself, one of the controversy for diagnosis dilemma for the physician, and would request my chairperson to introduce Dr. Kashyap Patel. Manisha Ben, will you please introduce, or should I?
Yeah, sure, I'll do that. I think
I can't share the screen.
So Dr. Kashyap Patel, sir, is a Wellcome Trust Career Development Fellow and Consultant Physician in Diabetes and Endocrine, with main area of research include genetic studies and clinical studies to improve the care of the people with monogenic diabetes. He was a Wellcome Trust PhD Fellow in prestigious MRC Protein Phosphorylation Unit in Dundee. After PhD, he obtained Wellcome Trust postdoctoral fellowship and studied monogenic diabetes in Exeter with Professor Andrew Hursley and Professor Sian Allard. He is a recipient of prestigious Young Investigator Award from Diabetes UK and EASD SGGD for his work in monogenic diabetes. He has published more than 40 papers on monogenic diabetes. And without taking much more time, I will hand over dais to you, Dr. Kashyap. Over to you.
Just one small comment. I think Dr. Panchal and Dr. Kashyap, you should clarify which Modi we are talking about. Sorry.
Yes, so that's fine. I will clarify. So you seeing, which one are you seeing? Are you seeing the presentation mode, or are you seeing the...
No, I meant was
but I'm just asking, sorry.
We are able to see both the slides. So I think,
which
it's
one
your
is it?
whole screen is now it is okay. Yes, perfect.
This is fine. Yeah. Okay, brilliant. So good afternoon, I guess, in Ahmedabad, everyone, and thank you so much for giving this opportunity to talk about one of the areas that I passionately worked for last 10 years. So I believe this is the diagnosis. If you make it, I think it's one of the most impactful diagnoses you can make. And although this is a genetic form of diabetes, and I'm particularly focusing today in one of the most common type of MODY, which is called HNF1A MODY, which is essentially happens due to mutation in this gene. I'm very confident that you all have a patient in your clinic without our knowledge of it. So let me start with Jay. So Jay is 34. He diagnosed with diabetes at 19. He was slim with BMI of 21, and he was treated as type 1 diabetes using basal bolus insulin therapy. He had HbA1c of 7.5. But one of the interesting fact about Jay was that he was actually missing a lot of his insulin, and it didn't really find to bother him at all. And he also had mom and his grandmom with diabetes. So although it sounds pretty standard history of type 1 diabetes, there was some clues here. The first clue was that he was missing insulin without much of a problem, and he had this dominant family history. So, of course, when you come across these sort of patients, the first thing you would say is that, oh, is it really type 1 diabetes? Am I correct? And actually, when we did test him, we found that he had islet autoantibodies were negative. And actually, when we checked his C-peptide, which is essentially allow you to measure amount of insulin you measure, the endogenous insulin, he had a 400 picomole, which was significantly higher compared to what you expect in someone with type 1 diabetes after nearly 10 years. And he also had this dominant history, as you can see on the right side. So obviously, this is not a type 1 diabetes and something else going on. And we then ended up doing genetic testing, which confirmed that J had a mutation in this gene called HNF1 alpha, and we call them HNF1 alpha MODY. So why does it matter? Is it just a fanciful research thing Kash does, or is it something important for Jay and his families? And actually, it turns out this is a very important clinical diagnosis to make. Because of this diagnosis, we were able to stop his insulin treatment, and actually he was managed entirely with gliclazide, and that's a very small dose. Those of you familiar using this drug, and essentially, despite of using a small dose and stopping insulin, his HbA1c actually substantially improved. So it is a worth a diagnosis to make, and not only for Jay, but it would also help in his children in the future as well. So let me just go back one step and talk about what is really MODY is. Now, I'm sure most of you know what MODY stands for. It is actually stands for maturity onset diabetes of the young. Now, it turns out this is a very phenotypic description of MODY. So it is simply means that it is a diabetes which started very early in life. So it's kind of young onset diabetes, but it has features of maturity onset. So typically like type 2, that it was not requiring insulin, but it had this dominant inheritance, and they found to have a beta cell dysfunction. And it was first really described back in 1974 by Tattersall. So it is really a phenotypic description. But when you start, let me just have a pointer. Present, no, yeah, pointer visible. Yeah, okay. So when we actually then started doing a genetic studies, it turns out that it is far more heterogeneous than one would have expected. So these are very two recent data from us in Exeter. The left-hand side, we took everybody that we have with MODY and looked at what's the commonest causes. And as you can see, the HNF1 alpha is the second, sharing the podium with glucokinase MODY. And actually, the reason why the HNF1 alpha is the second is because we test lots of people with mild diabetes, which is a very typical feature of glucokinase. But if you only look at in people with diabetes, you find that actually 1 alpha is the first most common cause. Now, this is the data from the UK, and it's about 1/3 of patients would have 1 alpha mutation. But actually, in the Indian studies done by Mohan, as well as the groups also found that 1 alpha is the commonest cause there as well. So I think you're all wondering that, is it really worth an effort? You know, genetic testing is expensive. How common really these things are? How likely I'm going to come across these patients in my clinic? Well, there are lots of estimates. Pediatric estimates as well as suggest that it's about the upper mark of around 3%, and they are mainly coming from European studies as well as studies in Turkey that we recently did, as well as in UK. In the adults, there is actually only one population-based study which kind of says about 3.5% of diabetes are diagnosed under 30. Now, this is done in Southwest UK as well as in Scotland. But we don't have such a large-scale studies in Indian subpopulations. And I've listed these 4 studies, which are kind of the largest studies conducted in India, where they looked at the MODY in people who fit the clinical, very old phenotypic definitions, and they found the rate very ranging from 7% to 19%. So you can see that it's a wide range, and it's really driven by the way you select these patients. But despite of this really important clinical implication, we have now shown that about 77% are not really diagnosed in the UK. So we have, despite of our knowledge, made a lot of improvement, but we have a long way to go. And I suspect this is highly undiagnosed, even more in Southern Asia, due to lack of access to genetics lab, as well as the expense of doing genetic testing. So we have a lot more ground to cover on the MODY. So why there is a problem? So why we can't find a lot of MODY? Why we just simply just say, this person has a MODY, and why would not be able to? Why there is an issue here of finding this? Apart from having a lack of access to genetic testing, which is important, but one of the main reasons why we struggle to find patients with MODY is because their clinical features actually overlap with other common diabetes we come across in the same age range. So let me just take through these 4 important features. The first is the age of diagnosis. So here you can see in the blue is a 1 alpha as well as 4 alpha, which is another common cause of MODY. You can see that age of diagnosis overlaps with type 1 diabetes as well as type 2 diabetes. This is BMI, and you can see the 1 alpha overlaps with type 2 diabetes and is actually almost identical with type 1 diabetes. And this particular, the overlap between type 2 and type 1 alpha is probably even more in Indian subcontinent population due to having a BMI, diabetes at a lower BMI. You can also see that HbA1c is highly overlapping between type 1 and type 2 diabetes. And finally, the parental diabetes, one of the cornerstones of autosomal dominant inheritance, are significantly high in 1 alpha and other forms of MODY, lower in type 1 diabetes, but then you also have a high rate of type 2 diabetes. And this is, again, significantly higher in the South Asian population. So because of these overlapping features, only half of the patients actually have a really classical phenotype. What that means is that if you really pursue this classical phenotype, you're going to miss a lot of patients, and we need some better things to do. And we just looked at some of the data in South Asians that this is actually even a harder climb for you all guys because of this lower BMI of type 2 diabetes and higher family history. And we actually see that effect here in the UK, that we took some people with white European ethnicity and compare them South Asian, the people who referred to us in Exeter for genetic testing. And you can clearly see that we were able to find genetic cause in 1 in 3 white Europeans, but only about 12% in South Asians. And I think that's because we are not well prepared, and as well as lack of evidence of how better to select these patients to genetic testing. But one of the few things which picked up on this very small study was that actually the South Asian MODY were diagnosed earlier, and as well as they had a lower BMI. So it is possible that we would be able to modify some of the features in order to improve our ability to detect them. So, but how are we going to combine all of those complex features I just talked about? Age of diagnosis, HbA1c, family history, BMI, it's very hard for a human mind to put all of things together and say, yeah, that's a MODY, because it's not. Even I can't do it, despite of working on this field for a while. Well, that's where you need this calculator. So this is developed by Bear Shields in Exeter. And what it is really is a very simple statistical model, which gives you a probability of your patient based on those characteristics, that how likely this patient has a MODY. And I would highly recommend that you use this calculator, because it's virtually impossible for human minds to comprehend all those probability in your mind. And it uses very simple clinical features, which you have access right in your clinic, such as age of diagnosis, sex, what treatment they are on, BMI, HbA1c, and what age they are, and their parent are affected. Now, and we also have an app available, so you can use actually on your phone while you're chatting to patients when you come across something you don't want to know some information about. Now, the downside of this calculator, which is widely used, you can see more than 2,000 hits on our website, and it actually has been used in multiple ethnicities, including South Americans, Africans, and Arabic, as well as in some Indian population. They've applied this calculation. They do work well, but it is only validated in the European. But good news for you guys that BAV is actually just secured a large grant to develop this in the South Asian population. So we would have something very specific to use for it. So apart from using this calculator, there are 2 rule-out tests you must do when you kind of think about MODY. So the first rule-out test, and these are rule-out tests in a patient who are insulin treated, really, is that you need to do C-peptide. So if the patient has a low C-peptide, is virtually exclude the diagnosis of MODY. So and that's really because type 1 diabetes have severe beta cell dysfunction, which beta cell destruction that we all know, and therefore, whereas MODY do not, and therefore it provides such an amazing discriminating power of using C-peptide. So the rule out test 1 is do C-peptide, and if they're lower, you would just forget about MODY. The second rule out test I would suggest is an islet autoantibody. So we've shown this here before, nearly 10 years ago, that MODY patients not being autoimmune don't have islet autoantibodies, whereas type 1 diabetes, around 90% have their autoantibodies. So you can simply just do autoantibodies in patients with insulin treated, and if they are positive, you can completely forget about MODY in that particular patient. So in summary, I'm going to propose a potential pathway which you guys can use in your clinic right now to identify some patients for genetic testing. So you would only think about MODY in a young onset diabetes because the rate of MODY goes down substantially after 30. So I would say focus on under 30. If the patient is insulin treated, I would suggest you, every patient is insulin treated actually, I would make sure that you exclude type 1 diabetes as a diagnosis. So you must do C-peptide and antibody positive, autoantibodies if they are positive at diagnosis, or they are long duration, then just do C-peptide. And that way you'll be able to exclude type 1 diabetes quite clearly. And then you're going to find people who's got persistent C-peptide and they are antibody negative. Those are the ones where you need to put a MODY calculator on. If the probability is more than 10%, I think you need to consider genetic testing. Now, before we have this South Asian specific calculator, I think for the time being, you can consider adding a couple of BMI points on your patient to make it align with a European. And this is just a cop-out, but I think it would give you a reasonable estimate. The reason why to go with a lower probability is because it has a massive impact on your patient, because you're going to change the treatment and you don't want to miss a lot of people. If your patient is non-insulin treated, then I think in the young onset, and I think then all you have to do is to run their phenotype through the MODY calculator, which you can do it in sitting in a clinic. And really, again, if the probability, and just add a couple of BMI points to counteract the South Asian BMI, and then look at the probability. And you can pick one of those two thresholds. I would suggest that because of the constraint of the money, you can go with the 50%. If the probability is 50%, you can just really consider genetic testing on that individual. So this is really a simple pathway which just takes away all the thinking from your mind, but let the existing evidence that we already know takes over and identify patients for MODY. Okay, so once you find it, you've done this and you said, I found a patient, and you've done the genetic testing and it turns out, wow, it's got a HNF1 alpha MODY. So how are you going to manage that? Well, there is a randomized trial done by UN Pearson back in 2003 showed that actually these patients are super sensitive to sulfonylureas, and they are actually 4 times more sensitive to sulfonylurea than type 2 diabetes. So this is the only third randomized trial in MODY, and you can clearly see that the gliclazide had a massive effect in 1 alpha MODY, whereas metformin had no or little effect. So we do not recommend using metformin in this patient. And I would suggest you start with a really low dose of 20 milligram and then titrate up as you need. And if you get it right, there is 80% of people would be able to stop insulin. So it's really, really important diagnosis to make. But you have to do it early, because if we do not find these people early in the life, they are less likely to be managed by sulfonylurea alone. And achieve the better glucose control. So this is the study we did a few years ago. We've shown that if you have a shorter duration of diabetes and if you have a lower HbA1c when you identify or when you have a genetic testing, there is a very high chance you would be able to actually manage by sulfonylurea alone. You don't need any additional therapies. Whereas once the diagnosis gets later and later, the chances of you actually finding people with managing alone with sulfonylurea is substantially lower, and this has to be, sorry, this is a mistake, this is more than 8.5, this is less than 8.5. So you can see that if you have a poor control at genetic testing and if you have long duration, you are unlikely able to manage with sulfonylurea alone, and you would need some additional therapy. So then the question then comes is that what are the additional therapies I can use if I come across these patients? Well, we have two drugs to choose from, and the both has this randomized crossover trial from Tina Wisbol from Steno Diabetes Center, and one is a DPP-4 inhibitor. If you are just above the target, I would recommend giving a second oral agent, DPP-4, of agent of your choice. And this crossover trial showed that if you combine with DPP-4, you would have a slightly better glucose control compared to SU. You can also consider GLP-1 receptor agonist. Although this is not as good as sulfonylurea, it is certainly useful, and particularly in a patient who are slightly obese with HNF1 alpha MODY. So this is what I would recommend to try with this. If you struggle with this, then I think we often use just a basal insulin, which works fantastic because you got such a huge amount of endogenous insulin. Having a once a day or twice a day basal insulin, it just achieves the fantastic control. But you got these options. Is there anything else you need to know? Well, there are two important things you need to know about 1 alpha MODY. Is that these people have a higher rate of cardiovascular risk. So this is the study done by Anna many years ago in Exeter, and showed that actually if you have 1 alpha MODY, you die early compared to unaffected relative members. And actually, and same is a male as well as females, and when you actually went back and looked at it, what the real cause, it turns out, is that most of the people were dying because of cardiovascular disease. So we now recommend that you use statin early in this patient compared to any of your type 2 diabetes patients to prevent this excess risk of cardiovascular disease. And we actually right now don't know why these people have a higher risk, because they actually have a slightly favorable lipid profile. So we actually don't know why these people have higher risk. So the other thing which you might come across if you randomly investigate these people with ultrasound scan, or they had an incidental scan, is the liver adenoma. HNF1 alpha MODY patient has been reported to have liver adenoma, but it's not really clear what they are doing there. Most of them are benign, and natural history is not particularly clear. And actually, there are more harm by putting a needle in the liver and trying to work out what it is. So I think we do not currently recommend you do any investigations of liver adenoma and just let it be, rather than actively pursue and scan through it. And the reason being is that no one knows how to manage them and what to do next. So at the moment, we are not doing anything with them, but it is a not common, but one of the rare features of it. And then finally, because 1 alpha's role in kidney, these people have unusually high glucose in their urine. Now, this is a fascinating feature, and a lot of patients come to us, particularly from Army and then the RAF, the Air Force, when they are actually been screened for diabetes. They are found to have this glucose in their urine. They're saying, this is impossible. I'm the fittest guy on the planet. How do I have a glucose in my urine? And those people actually turn out to have a HNF1 alpha MODY, and you probably will come across something if you're working in that particular area. And actually, these people have a glycosuria despite of having base control. So it is not a feature of poor diabetes control, but it is just that the renal handling of glucose is not particularly great. And they are actually present also in people without diabetes. So it is inherent features of 1 alpha mutation. So I think what this means is that you can actually use this as a non-screening tool in children if they are doing a predictive testing. So if the GI has his children, is 2 years of age, you don't want to stab them with HbA1c for every year, but you can just simply take the urine and check the glucose as a non-invasive monitoring of onset of diabetes. So that's really handy. So in terms of the summary of the treatment, I would recommend that you would stop treatment with insulin straight away and start them on a low dose SU, particularly start with the gliclazide 20 milligram once a day. If they have a really long duration of diabetes at genetic testing and higher HbA1c, then I would suggest that you add the gliclazide, stop the short-acting insulin, but continue the basal insulin for that time being in that particular patient, and then really optimize the other therapies, either DPP4 or GLP-1 receptor. There is a question is that whether can we use SGLT2, which is becoming really favorable right now due to the cardiovascular profile. And I think it is something to consider, but we are a bit worried about the glycoside aspect of 1-alpha. They already have it and what the combination might do to them. So we are a bit cautious about that currently at the moment. I would also recommend to start them on statins for primary prevention, and probably earlier than you would do in type 2 diabetes patients. In the UK, we would recommend to start them from age 40. I would suggest do not investigate liver adenoma, let them be. And finally, you can actually exploit the glycosidia to, particularly in children, to predict the onset of diabetes. If they are, once they hit at 10 years of age, you can use the yearly HbA1c to identify early onset. So here is my take-home message. The HNF1A MODY is the most common cause of MODY that you're going to come across. The diagnosis make massive impact on the patient, particularly the one who are insulin treated. And majority of them are missing. So you would need to have very high vigilance when you come up sitting in the clinic. I would highly recommend to use biomarker and MODY calculator in all your young onset patients to systematically see through them to find patients who you can do genetic testings. And once you really find the diagnosis, you should treat them with a low dose sulfonylureas. So this is all from me, and I really like to thank a lot of funders who have been funding me for this work for over a long time, as well as the fantastic team that we have in Exeter, as well as patients and the physician who referred this patient to us. So thank you very much.